Thank you. Thank you to Dr. Sabu, Dr. Joshi, and the organizers, and thank you to the chairpersons for inviting me to my country of birth, my home country. So I'm going to briefly touch upon the future of metabolic medicine over the next 5 to 10 years. But as someone said, who can predict the future? So I would like to start with a quiz. So we know Banting and Best. They have the pioneers who discovered insulin almost 100 years ago. But can anyone name the dog? Marjorie, there we go. Well done. Congratulations. Yes. So that was the most important person in the triangle and for the discovery of insulin, because without Marjorie, we wouldn't have had insulin. All right. So I'm going to go straight into some of the newer emerging and the future therapies for predominantly diabetes, both type 2 and type 1 diabetes. As you know, lately there have been some talk about these very long-acting insulins, or once weekly insulins, that is given almost like a long basal insulin injected once a week. And the one on the left side is called icodec, which has been in clinical trials, but these were recently not approved by the US FDA for use in the States because of risk of hypoglycemia. And the other one is the insulin BIF. Now, as you can see, icodec has a strong reversible bonding to albumin in the circulating plasma and has a half-life of almost a week, while the other insulin, the BIF, has a half-life of almost 17 days. So really, they're very, very long-acting insulins and provides basal insulin coverage when used in humans with diabetes. So this was one of the earliest studies of once-weekly insulin, or icodec, a randomized open-label comparison of once-weekly insulin icodec titration strategies versus once-daily glargine. And the figure on the right side shows the approximate time in range. When you look at the readings of the continuous glucose monitor, the percent time in a 24-hour period between 70 to 180 milligrams per deciliter is the desirable time in range. So the time in range with insulin icodec with various titration schedules showed that at the end of treatment, they achieved a time in range, satisfactory time in range of between 70 to 85% compared to insulin glargine. So it was equivalent to insulin glargine, perhaps even better in these early open label studies. There was another study that was published approximately the same time when people have switched from once daily insulin glargine to once weekly insulin icodec with various titration strategies. And the figure in the top right panel shows that the insulin icodec increased the time in range to 73%, but of course at a cost of hypoglycemia. Because if you look at the little red bar or the red segment of the bar diagrams, the long-acting, the once-weekly insulin certainly has a high potential of hypoglycemia. And that is perhaps one of the reasons where the US FDA did not approve icodec yet. What are the pros and cons of these newer, long, or really long-acting insulins? Perhaps some less hypoglycemia, because there has been some studies that have suggested that, but these have been shorter duration studies. There's, of course, less intra-individual variability, equivalent hemoglobin A1C controlled, increased flexibility on insulin dosing timings, and increased adherence when compared to daily injections of insulin, and certainly lower workload for visiting nurses and care providers in the elderly population. And there has been some tantalizing reports that suggest that these long-acting insulins in type 1 diabetes can reduce the frequency of diabetic ketoacidosis. The cons, however, is, as I mentioned, hypoglycemia benefit not consistent across the types of diabetes. Benefit to cost ratio is uncertain and is usually preferred in those with fairly stable glucose control, predictable lifestyles, and low variations in basal insulin requirements. So still there's a lot of work to be done before these insulins see the light of day. Non-insulin therapies, what's new? Of course, our previous speaker spoke extensively about the longer-acting GLP-1 analog, so I will try and be brief so I don't repeat the same things that were said before. It's very important to note that longer-acting GLP-1s compared to the shorter-acting GLP-1s has a greater response to lowering of hemoglobin A1C, fasting glucose, and reducing body weight. The shorter-acting GLP-1 analogs like liraglutide or exenatide have less effects on each of these variables or each of these outcome variables. Again, as has been shown elegantly by my previous speaker, the longer-acting GLP-1s have shown benefit in cardiovascular outcome trials, ELIXIR, the leader, SUSTAIN-6, and so on. SGLT2 inhibitors, again, as we have heard before, they have much more benefit effect than just glucose lowering. It is cardioprotective because it causes sodium loss or natriuresis, lowers blood pressure, reduces arterial stiffness, certainly lowers plasma volume because of the diuresis, lowers cardiac preload, reduces inflammation, and improves cardiac remodeling. It also seems to increase ketone utilization, although there's a risk of diabetic ketoacidosis, certainly in patients with type 1 diabetes. It has also been shown to be renoprotective by causing natriuresis, lowers hyperfiltration, reduces albuminuria in certain trials, reduces intraglomerular pressure, hence benefits the kidneys, and reduces renal inflammation. So certainly there are much more to SGLT2 inhibitors than just glucose lowering. Again, and this is a summary of cardiovascular outcome trials of all these various new classes of drugs that I will not belabor. There was a recent study that came out that showed that the efficacy and safety of once daily oral semaglutide, high dose, 25 milligrams and 50 milligrams, compared with 14 milligrams in adults with type 2 diabetes in the Pioneer Plus study. We showed that the higher dose oral semaglutide causes greater reduction in hemoglobin A1C and greater reduction in body weight compared to the 14 milligram dose of semaglutide. What about the dual and triple agonists? Again, I won't belabor this because of the prior speaker has talked significantly about this. But these are some of the premise of these medications was based on bariatric surgery, induced changes in gut hormonal milieu, augmenting the release of incretins, the GLP-1 axis. We all know that Roux-en-Y, gastric bypass surgery, and sleeve gastrectomy increase both GLP-1, GIP, and glucagon hormone levels. GLP-1 and GIP lower fasting and postprandial glucose. GLP-1 and glucagon lowers appetite and increase energy expenditure with net weight loss. And as we know, GIP-1 also affects appetite and energy expenditure. Tirzepatide, or Mounjaro as is known in the US, has exploded into the scene as far as management of type 2 diabetes and obesity is concerned. It's a 39 amino acid linear polypeptide. It's once weekly injections. It has a higher affinity for GIP receptor than the GLP-1 receptor, and it inhibits GLP-1 receptor internalization. It also has been shown to increase adiponectin levels. And in several phase 3 clinical trials, the SURPASS trials 1 to 5, it has shown benefit for people with diabetes, obesity, and NASH, or currently what is known as MASH or MAFLD. To summarize the actions of GLP-1, GIP, and glucagon agonists, they cause robust reductions in hemoglobin A1C, weight, and increase the percentage of patients reaching hemoglobin A1C target when compared to placebo, semaglutide, or basal insulins. But again, I will stress upon the need for monitoring of GI adverse effects like nausea, diarrhea, and vomiting, especially for people with long-standing type 2 diabetes, and also in patients with type 1 diabetes where it's off-label use. Because as we know, long-standing patients with diabetes, because of autonomic neuropathy, have a predisposition to delayed gastric emptying. In fact, a study that we did at Mayo Clinic when I was a junior faculty there showed that up to 50% of patients with type 1 diabetes over the age of 10 to 15 years have abnormalities in gastric emptying and gastric motility when you do motility testing. And the majority of them are completely asymptomatic. I've actually seen in my practice at least 2 patients that were treated off-label with tirzepatide developed severe gastroparesis after even 6 months of use of this medication. So we have to be very careful when we prescribe these medications to patients with long-standing diabetes, predominantly type 1 diabetes, but also type 2 diabetes. For the interest of time, I will skip to the next few slides and talk very briefly about retatrutide, which is the triple agonist that has been mentioned before. In clinical trials, this has been shown to achieve almost a 20 to 25% weight loss on obese adults without type 2 diabetes. And who knows, it may replace the role of bariatric surgery and sleeve gastrectomy as a main therapy for obesity. But again, these are new kids in the block, so we have to be careful before we prescribe them willy-nilly and long-term. What about type 1 diabetes? A lot of people talk about type 2 diabetes and obesity, but we should not forget type 1 diabetes. There are newer agents that are coming into research and into fore. One of the old drugs, the calcium antagonist, the verapamil, has been shown to be beneficial in patients with type 1 diabetes, in early onset type 1 diabetes. Now, there is a protein called TXNIP, or thioredoxin interacting protein, which is upregulated in patients with type 1 diabetes. And this is a topmost glucose-induced gene within the beta cells. And the effect of these upregulation is that it causes apoptosis of the beta cells, and that has also an effect on alpha cell function, which I will explain in the next few slides. So in a study that was published by my colleagues in Nature Medicine a few years ago, Dr. Ovale and Dr. Shalev, they looked at the effect of 360 milligram once daily dose of verapamil in early type 1 diabetes versus placebo. And they found that the C-peptide in response to a glucose load was better preserved with type 1 diabetics on verapamil than on placebo. The total daily dose of insulin was also reduced in these patients who are on verapamil, and the hemoglobin A1C lowering was more with verapamil and insulin versus insulin alone. A novel class of oral non-immunosuppressive beta cell targeting medications has emerged. And in fact, my colleague at UAB had just received approval from the FDA and has an NIH grant to do a clinical trial of this medication. So this is a novel concept. It is non-immunologic. It does not affect immune tolerance. So what it does is that it inhibits the TXNIP, which is in blue. Now the TXNIP inhibition stimulates insulin release and insulin secretion by the beta cells. It reduces beta cell apoptosis, and at the same time, it also reduces glucagon secretion, because as you know, in patients with type 1 diabetes, there is not only lack of insulin, there is also increased glucagon, because the paracrine regulation of alpha-beta cell intercommunication is affected. So this medication or this protein has been shown, stimulation of this protein that is upregulated in type 1 diabetes causes beta cell apoptosis and increased glucagon secretion. So if we inhibit this, it can reverse both of those abnormalities. So we are currently starting a clinical trial at the University of Alabama and other centers of this drug in early type 1 diabetes to see whether it improves both beta cell function and mitigates alpha cell dysfunction. There are also very many other modulators or type 1 diabetes modulating approaches with various medications, including GLP-1 agonists that are currently in the pipeline, some in animal studies, some in early clinical trials. And I've just put in a list of those. The most important one is teplizumab, which, as you know, has been approved for use in the US by the FDA for use in early type 1 diabetes. And this was a study that was published in the US where the trajectory of beta cell function and insulin clearance in early or stage 2 type 1 diabetes showed that use of teplizumab over a 12-month period improved insulin secretion in the figure A, did not change insulin sensitivity because it mainly stimulates beta cell preservation. It improves disposition index and reduced insulin clearance. What are the drugs on the horizon? Again, there are various agents that are currently in various either animal studies or early clinical trials, including oxyntomodulin, glucagon receptor agonist, the GPCR40 agonist. There are medications that also has been shown to benefit hepatic glucose production in patients with type 2 diabetes. There are also insulin sensitizers that are currently on the bench and the pipeline, including the PTP1B antisense oligonucleotide inhibitors, etc. Finally, a brief mention about smart insulins. Smart insulins are insulins that do not cause hypoglycemia. Again, these have been mainly in animal studies. So these are insulin that stimulate glucose uptake only when the glucose levels are elevated, not when the glucose levels are normal. So there are multiple papers that have come out over the last few years that has talked about the use of smart insulin. So to conclude, promising novel therapeutics for management of metabolic diseases, including type 2 diabetes, obesity, and MASH are imminent. Innovative approaches for prevention of beta cell loss, together with restoration of beta alpha crosstalk, and therefore mitigation of concomitant alpha cell dysfunction, are also on the horizon. And also watch out for non-hypoglycemic insulin. Thank you.